Melanie. I am a nurse and I've been involved with Dementia Alliance since before it was Dementia Alliance. And Lisa and I have been friends and colleagues throughout a good portion of that time, not the whole time, but just because we didn't know each other, not because we didn't like each other, but we've been friends and colleagues as long as we know each other. So it's good to be. So the title of this one, and thankfully, thanks to the Dementia Alliance for inviting me to be here. And the topic of this one is kind of the theme for the month. And the theme for the month is really about managing dementia and other health conditions. So that's really what we're going to be focusing on today. And I'm using a really very broad definition of what we consider health conditions. And so that might be anything from how to get the person to take medications to what about falls to urinary tract infections and skin, and we're just going to put all kinds of things in there. So I am delighted to be with you to have this time to kind of talk about this. So I'm excited that it really is a Q&A. So we're going to really have some time to really talk about some of those things. So I've just got a couple of slides. Most of what I've got pulled up is going to be just in case we need it for resource. I want to say something. I need to get permission from Lisa for this to be true. Dementia question answer, managing other healthcare concerns. What was kind of in my mind, what kind of popped up in my mind were things like physical things like heart disease, managing heart disease when the person has, or diabetes with what people want to eat and want to drink, and managing cancer kinds of, should we do the screening? Should we not do the screening? Should we manage should we do the screening if we're not thinking how long are we going to do lower GI series? How long are we going to send people in for mammograms? You kind of have some of those conversations. Managing infections like urinary tract infections, pneumonia. Do we continue to do those, or when is it time to kind of say enough? Emotional issues, things like anxiety and depression, and then maybe even if it's what you're interested in, things like taking medications and managing nutrition and managing mobility and managing bowel and bladder kinds of things. So I'm gonna so this really is a question and answer. And so Lisa sent me some questions that people had submitted ahead of time, and there also may be some questions that you didn't submit ahead of time. So I am going to ask if you
I'll get started. This is Malia.
Hi, Malia.
So I had sent in a couple of questions related to, and by the way, this is my first time in these. I guess it's a monthly Q&A, so I really didn't know it was going to be more of this style, but that's okay. I'm really getting started in this journey, and as a second tier caregiver to my mom, my dad's still alive and at home, and I'm 6 hours away. So I'm trying to do as much educational work to keep him informed as I possibly can and to prepare myself. So the couple of questions that I submitted earlier in the week were related to medications, not really at that point yet, but mom is stubborn and hard-headed, and I think we're going to see that exacerbated, as this disease continues. So just managing that, how do you, what are some best practices or ways to just ensure medication is taken? Again, haven't really dealt with an issue yet, so I don't have a specific situation. So just looking to maybe get some thoughts or conversations started on that.
So that is a really great question. And it really does relate back to managing medical problems and other kinds of issues. So I kind of start with, so we've got three things we can work on. We can work on the medications, we can work on our interactions, and we can work on the other kinds of environmental kinds of things. So if we think about the medications, the first place I usually start is, do we still to have a good review of the person's medications? And what I mean by that is to really have somebody, a really good pharmacist, a good primary care provider, really look at the medications and say, do we still need this? And how do we still need this? Because a lot of times people get started on medications that make sense for a while, and then they don't make sense forever. So I would kind of start with, how do we simplify this medication regimen? Is there something that we can try that that might be easier? Is there something that instead of being 3 times a day might be 1 time a day? So really start with saying, how can we simplify those medications? And then the next thing I do is I look at the form of the medication, because pharmacists and physicians have gotten much more creative, and nurses as well have gotten much more creative in how do we provide the medication. So there are compounding pharmacies that can take a medication and make it into a lollipop, or can take a medication and make it into something that you rub into the skin. So it can be absorbed through the skin. So, or something that you put it in your mouth and it dissolves, instead of having to eat it or chew it or something. So there are all kinds of different options like that. So I would start with really looking at the medications. The next piece I would look at is kind of the history of how the person used to take their medications. So for example, if I'm used to getting up in the morning, taking my medications in the bathroom before I brush my teeth, and then going downstairs and having breakfast, if my care partner wants to give me my medicines downstairs at breakfast, that's not going to make sense. So trying to kind of replicate that history, kind of what makes sense. How did the person used to do it? Is another piece that I try to do. We get really weird about medicines. And so, as nurses, we think that medications don't count unless we put them in a little paper cup. There's something about a little paper cup that activates medications and makes them work. And it doesn't, so you can put them on a plate, and they still work. So it's whatever. So kind of thinking about, how did the person used to do it, and kind of keeping that as consistent as possible. People will do things, trying to make things. So people do things like they'll start crushing medications and doing things like that. Sometimes that works, but sometimes that can get you in a lot of trouble, because sometimes what happens when we crush things is they're little pieces of it. So I eat my yogurt and I find little pieces of gravel in it. So then I think the yogurt is poisoned. So we've got to be really careful about those kinds of sneaking medications in, and be really aware of that. So for example, I might use raspberry yogurt because it's got kind of seeds in it a little bit, or the yogurt that's got the mix-in fruit because it's got more textures in it than a really smooth pudding where it's going to be really clear that that's a foreign body. There's gravel in my pudding, and why would you put gravel in my chocolate pudding? And so, it kind of makes it more difficult like that. So that's the second thing. The third piece is kind of that approach kind of thing. And that has to do with things like not having it become a confrontation. So you've got to take your medicines. You haven't taken your medicines. Why won't you take your medicines? Instead, Mary, your medicines are right here. So it's more kind of giving information and less kind of that thou shalt take thy medicines, that more kind of confrontational kinds of things. So I would try to kind of do those things. The other thing that I forgot to mention that makes a big difference is, so do this with me. Kind of tilt your chin up a little bit, everybody. Kind of tilt your chin up, and now take 3 deep breaths. Now swallow. And what did you notice? Was it easy to swallow or hard to swallow? And for most of y'all, it gets really hard to swallow when your chin is up. It gets hard to swallow. Or turn your chin and try to swallow. And so a lot of times when we're helping people take their medicines, we stand up, and so their head is up, and so then their airway is open, and it's not safe for swallowing. So that's kind of making sure people are in a really good functional position to take their medicines. The other thing is if I were with y'all, I would give y'all all a Skittle and have you breathe with your mouth open a couple of times. If you've got Skittles or Tic Tacs or something, you can try this. But breathe with your mouth open a couple of times and then try to swallow a Tic Tac or a Skittle. And what you'll find is, because you've been breathing with your mouth open, what do you think happens to your mouth and lips and tongue? It gets really dry. And so then when you put the tablet in there, what happens? It kind of sticks. And so then people have this thing in their mouth that they want spitting out and getting rid of. So those are a few things about taking medications. Do any of those seem like they might be helpful, Malia? So you can unmute so I can hear you.
Yes, thank you.
Yeah, and that's kind of the approach that I take, to all of these kinds of things. Are there things about the medications, or about the situation? Are there things about the environment? Are there things about our approach, or things about the issue, things about the past, what's familiar, what's unfamiliar, and then things about our approach. So we'll kind of be using that pattern probably pretty often as we go through the night and the questions. And we do have some other more, Malia, we do have some other more presentation topic based kinds of sessions. And this one's just kind of identified as a question and answer. So hopefully we'll have some good conversation and questions. So thank you.
Melanie, while you're on the topic of medications, I get a lot of questions from family caregivers about supplements.
Mhm.
Either the person has taken supplements their whole life, should they stay on them, or should we start supplements? Is there any benefit to starting some supplements to help us be healthier longer while we've got dementia? And I know there's a lot of confusion. I'm not asking about specific medications. Rather, is it good to continue on those sort of extra meds, or start new medications when we have dementia?
I think that's really dependent. So if somebody has been taking something for a long period of time and it seems to be working with them, it doesn't seem to be bothering them. There are a lot of things we don't know, especially about supplements, that we really don't know. So if it's not creating problems, I'm probably not going to create problems. As far as starting supplements, most of what I've read is that supplements are better in kind of that prevention, kind of not prevention, nothing can really prevent, but kind of that reducing risk kind of thing. So that's when those supplements might make sense to kind of start having. And also with a lot of supplements, what we really find is, do y'all remember when I think it was ginseng was supposed to save the world, and people who took ginseng were healthier and living forever. And what we found out was people who take ginseng who live in Asia, there are also a lot of other things that are different about them than the extracted ginseng components that we put into tablets. So there does seem to be something about whole foods that, there's a difference between drinking a tea made out of ginseng or made out of echinacea or made out of something, then there is eating a powder that's a derivative of that plant. So whole foods seem to be not food from Whole Foods, although Whole Foods is wonderful, but meaning eating food, getting your nutrition from food seems to be better than supplements. The other thing I will say is some people go really quickly to some of the nutritional supplements for calories and things like that. And some of those can be good. And you also can often make things like peanut butter smoothies with pineapple in them. That maybe not pineapple, maybe peanut butter and strawberry smoothies or something that can have a lot of calories and a lot of nutrition and be really good for people. So was that good enough, Lisa? Was that kind of what you wanted, or do you have a different opinion? Because you're really educated about this stuff as well.
No, I don't have a different opinion. I agree with you. I think, like you started out saying, as we move further into dementia, if there are medications, supplements, whatever that we can take away, because it's easier for the person to not have to swallow pills or whatever it is. But if those things are helpful, if it's something that they've really been committed to for a long time, then I think it's definitely, if it's not causing a problem, we can continue on with that. So yeah, I agree with you.
And that's a great example. If someone is taking, a multivitamin that's this big and they're really barely swallowing ice cream, it might be time to start thinking about, do you want your last bite to be that multivitamin? Or that big old calcium, hunkin calcium tablet or something. Do you want your last moment of food to be that? So we do start having those conversations. So thank you for bringing up that perspective as well. So what other questions do you have about managing health conditions when dementia's around?
Well, I just wanted to say that I'm really here just to listen. I'm opening up a family care home in Raleigh, so I wanted to kind of get an idea of, some things that could come up. So I may not have a lot of questions right now. Maybe some will come up later, but a lot of this is just me listening so I'm, familiar with things to look for.
And some of those things about medications may be helpful.
Yes, I took a lot of notes on that. So yes, definitely.
So that piece might be helpful. The other piece that's helpful sometimes is thinking through, why are we still doing things? For this screening, does it make sense to still do this colonoscopy? Maybe it does, maybe it doesn't. So that's going to be different for each person in different situations. So Sue, you turned your camera on. I'm wondering if you've got a question, or are you just in a position now where you can turn your camera on? So you don't have, you have to be quiet. Okay. So you can type in the chat if there's something you want to add, Sue, or ask. That would be great as well. So what about for Sherry or Danielle? Either of you want to unmute and ask a question, or did you already put something in? Yes, Sherry.
Well, just like Shauna was saying, I'm here to listen. My background is I've worked at a hospital in Charlotte for 25 years, and I started working for a group called Care Weavers in August. And so while I've worked with people, older population, for most of my years at the hospital, that's primarily my client group right now. So I'm trying to gather as much information as I can. And it's very interesting about the medications, especially the part about, people thinking that you're poisoning them because of the granularity of the crush tablets. I mean, that's a brilliant thought. And that has always been kind of my question, is when do you stop doing what you've been doing and do something different? And so I'm very interested in this, grateful to be able to participate here. So no questions, just a grateful comment.
So I think we should, we should always ask questions, whether that's as a healthcare professional or whether that's as a family. I think we should always be asking questions. So if someone says, we really, we're going to recommend this echocardiogram, we're going to recommend this test, and this is, and my question is, so you really think this would be good? So tell me more about what that would tell us and what we would then do with that. Because if it's going to tell us something that we're going to do something, I'm all in. But if it's going to tell us that, oh, this is how we make the decision about if we're going to have surgery or not, and I already know the decision about having surgery or not is not, then, you know, why would I do that if it's not going to change the outcomes? So I'm going to go back to some questions that Lisa sent me. And I think one of the groups of questions that were sent to me was about mobility, things like not being able to mount balance and falling frequently and shutting eyes, and about vision and depth perception. And there was also one about when to try things like canes and walkers and things like that. So maybe we'll spend a little bit of time kind of talking about those kinds of things. And let me show you, I'm gonna share my screen. I'm gonna go back to my slides, and I'm gonna bring up one that will help us out with this, and it's this one. So this is actually your sensory motor strip, and your sensory motor strip, if you put your hands up like this, up on your skull and kind of curve them in like this, it kind of sits up here, and it kind of connects what you feel with how you respond. So when you look at this part of the brain, it's all, your whole body is mapped out across this. And what you've got just generally is you've got this gray matter around the outside, which is for storage. So that's where information is stored. And you've got this white matter on that's going through here, which is connecting all of this storage. So this is an autopsy photograph. This is a sensory motor strip of somebody who died without dementia. This is a sensory motor strip of somebody died with dementia. And so what you see is there's a lot less of that connection. There's a lot less of that storage. So what that means is, yes, mobility is impacted by dementia. So it tends to be things like how the body changes. So if everybody will stand up with me. So I know it's weird to stand up on Zoom. It is not against the Zoom regulations to have people stand up. I checked the Zoom regulations. It is legal to stand up on a Zoom call, because you wouldn't think it was, but it is. So if you stand up, and then if you pick your heels up off the floor, and you bend your knees, and you pull your shoulders towards your knees, so that becomes what dementia kind of does to people, that it kind of starts to kind of pull people in like this. So if I'm trying to walk like this, just take a few steps and see what happens. Was that pretty hard or pretty easy? Okay, so that is getting to be pretty hard. So that in itself gets to be pretty hard. And the other thing is, don't sit down quite yet. I'm not quite finished with you yet. Stand back up. So what I want you to do is stand up with one foot in front of the other. And if you need to put your finger, I don't want anybody to fall. If you need to put your fingers on your table, you can. But if you're standing with your feet like this, one heel to toe, you probably are noticing something that's happening. And what are you noticing is happening? You can feel your body working to kind of keep your balance. Now stand with your feet about hips width apart. Now, do you feel your body working to hold your balance there? You really don't. And so what happens is, I'm gonna sit back down. You can sit back down. So what happens is, part of dementia is that we lose fine motor. So for example, that fine motor that kind of controls our fingers, being able to use tools and things like that, our fine motor that controls things like our feet, our proprioception in our feet, our kind of ability to find our balance and find our way, our ability to manage things like chewing and swallowing is also fine motor. We hold on to our strength but we lose some of that fine motor. And so when we lose some of that fine motor, our feet, because we need more help balancing, come like this. So we get that broader base, which gets this walking that kind of starts to do like this. And it becomes harder when you're walking in that wide base. It becomes much harder to pick up your feet. And so then people start kind of sliding their feet, which means they're more likely to catch and trip. And I'm going to show you one more picture. So the other picture I'm going to show you, this, which is vision. So this is the brain of the person without dementia. This is the brain of the person with dementia. This is the occipital lobe, which is back here. And this is the occipital lobe of the person with dementia. And so what you're noticing is there's some loss there, right? So there's some changes in that brain tissue. There's some changes in what is available there to work. So what that means is that change actually starts out as normal aging, just like being a little more, taking a little more to store new information as aging, and that moves into disease where you can't get new information in. Vision starts to change when you get to be about 65 years. Well, when you get to be 25 years old, your vision starts to change. So, you kind of peak. So if you were to put your hands out like this and wiggle your fingers, you can see your fingers if you're under age 25. If you're on my side of 25, you have to start moving those fingers in to see them. When you get to be about 65, it kind of comes like this. So do this with me. Put your hands around your face like this. Now imagine you're in your car and you're getting ready to make a left-hand turn. So you put on your turn signal and you turn to look out the window over there. And notice how far you can see. So turn to your left and see how far you can see. Now turn back, drop your hands. Now look back to the left and see how far you can see now. And whereas the first time I could only see to about here. With my vision, I could actually see to here. And so people start having change. It's very similar to when you first started wearing your mask, with COVID, did you notice some trouble going downstairs? And it's because this part of your peripheral vision is kind of changed because of your mask. So that's part of some of the changes that people experience. Well, what happens with dementia is that kind of continues. So it actually goes from here. This is normal. This, if you put on like a scuba mask, so do like this with me. This is what happens to the vision of somebody with dementia. So kind of turn around and see what you can see and how it looks different. Now put on this. This becomes the vision of somebody who's kind of in that stage of dementia where I'm looking for people who I'm remembering the way things used to be. So I'm remembering when my mother was still alive and the kids were still little. So do this for me. Stand up behind your chair. Now put your hands on your chair like they're your walker. I guess your walker. That's my walker. So now put your binoculars on and kind of look straight forward and notice what you can see and what you can't see. So let's see if anybody's unmuted. Everybody is muted. Lisa, can you unmute for just a minute? I know, so I understand your situation. So Lisa, when you're standing behind your walker like this and you're looking where you're going, what can you not see?
I cannot see my walker or my feet.
You cannot see your walker or your feet. Now, when you look down at your walker and your feet, what can you not see?
Where I'm going at all.
You can't see where you're going. So what happens for people living with dementia is they have that change in vision. That means they're walking along like they've been walking along. They've got this vision, and so they truly don't see that footstool. They truly don't see that end table. They truly don't see that chair. They truly don't see that dog. And so they fall. And so the kinds of falls people living with dementia often have aren't the little dainty little, drop into the chair. It's head over heels down the steps kind of falls. So that's a little bit about falls, and that's a little bit about why some of the devices that we think should be helpful really don't solve all of our problems when we come to thinking about dementia. That all of those all of those things really don't work as well as we think they would, as well as they should work great with somebody who has a broken hip, or with somebody who had a stroke, or with somebody who has something. With dementia, it gets a lot more complicated.
So Melanie, if I have someone who physical therapy has been working with them and given them a walker, when physical therapy is here, they seem to be able to use the walker, but most of the time they just walk away without it. They don't remember that it's there because it's a new thing and they haven't grasped that. Do you have, I'm not asking you to solve the issue of the walker, but do you have any small little tips or things when someone's at that point where we think they might be starting to have more falls? Maybe they're not there yet, but we've got this apparatus they don't know how to use.
So I'm going to say a bunch of things, and they're all going to come out of the same mouth, and sometimes they're going to sound really different. And so one thing I'm going to say is walkers and canes and stuff can sometimes be falls hazards. So sometimes those walkers and those canes are things that are there for people to trip over and fall through. So they're not a universal answer. So, there are some things I do, going back to that medication review, I'm going to have that pharmacist review those medications and say, which of these could make the falls risk go up? Because they're medications that are good medications that make a lot of sense that might not make as much sense now. So I'm going to have them review those medications. I'm going to make sure that people always have on good footwear. So that there was a study that one of the VAs did a few years ago where they were having a lot of falls, and they had people start going to bed in those slipper socks, the slippers that have grids on them, and they found that falls went down. Because just simply having those socks on that had those grippers when people got up made falls go down. So I'm going to look at those kind of things. I'm going to try to get rid of as much stuff in the environment as possible. So I'm going to get rid of lamps that are standing lamps. I'm going to get rid of end tables. I'm going to get rid of things like that, that people might trip over. So I'm going to get rid of those kinds of things. And I'm going to, if the person really does need the walker, having said a lot of times to increase the risk of fall, one of the kinds of memories that people living with dementia can learn is motor memory. And so if we have the resources and the commitment and really work on that walker, really not in a naggy, why don't you have your walker? You're supposed to have your walker. But if we do it as a really kind of, oh, mom, hang on, your walker. And so we work on it, we practice with it, it becomes part, we make the walker something that's not just metal. Maybe we make the walker something that looks friendlier, so it's more attractive. So there's an emotional kind of, so we use the walker when we go outside because that's a really fun thing that I love. So then the walker becomes kind of associated with something that's fun and positive, and not just a, where's your walker? You're supposed to have, why don't you have your walker? So that kind of thing. So I'm going to do some, and then practice with it, work with it, practice with it, work with it in a curious, interested, just give it a try. Let's see how it goes. I think one of the other questions was about sit to stand, stand to sit. And I'm wondering specifically if we have the information, if that is when the person is sitting by him or herself or standing by him or herself. And so maybe that's the truth, is with those kind of things. So that kind of situation, I'm really going to then think about a couple of things. So one thing I'm going to think about is, why is the person standing or sitting by him or herself? So I'm going to start to kind of anticipate, because a lot of times people stand up. I mean, when do you stand up? When you're on Zoom and you've been on Zoom for 6 hours today, when do you stand up?
Go to the bathroom.
So to go to the bathroom. So a lot of times when people stand up, it's because they need to go to the bathroom. I'm not used to, as an adult, asking somebody to take me to the bathroom. So that's, Shauna puts in the chat, stretch. So, after sitting here for a while, I start to get restless. I need to get up and move around. So one of the things that can help with those sitting up, standing by yourself kinds of things is seeing if we can, and we never will anticipate all of them, and we never will be there for all of them, but see if we can initiate some of that standing, sitting at a time when we can be there. So then maybe potentially there's less of that alone standing, sitting, stand. The other thing I would say is there are these pressure pads that have alarms. I'm plus minus about those. Because what happens when I stand up and the chair starts screaming at me, I might try to get away from the chair and fall down. So I want to be, I'm not sure those are universally good kinds of things. The other thing is, the only way those work is if, when that person stands up, you cut the alarm off and you help the person do what they were standing up to do. So if you just sit the person back down and cut the alarm off, but they still need to go to the bathroom, or they're still feeling restless, they still need to get up and walk, then they're not really that solution. So I hope that was helpful. Some of the pieces of that was helpful, maybe. Okay. So so what were some of the other questions that Danielle, we haven't heard from you. If you want to drop something in the chat, or if you want to unmute, and why did you choose to spend this? Why did you choose to come to dinner?
Well, I'm in the dark here. I'm a master's student at the University of North Carolina at Greensboro. I'm gonna turn on the light. And I'm starting an internship at Wellspring in May at the half-day program for mild to moderate dementia clients. So I'm kind of just learning and trying to supplement my education with some practical things. I do have a extensive kind of medical background, so that's going to really help me, I think. But, just wanted to see if there was topics that would help me when dealing with the people that I'm going to encounter in my internship. So that's kind of why I came to join.
So
I don't have any direct questions per se, because I haven't really started. I don't start until May. So
another thing, I'm curious. Things as much as I can. So thank you for sharing, Danielle, and go be quiet so your puppy isn't distressed. People move around and the puppies get distressed. So thank you for being here. So what are some other, yes, Shauna?
So what can you discuss, like some techniques for handling hearing challenges in those with dementia? Because I know I see a lot. I've been a nurse for 10 years, and I'm sure I see this a lot. People just kind of yelling at people, and they think that's the best way to communicate, is just screaming at them because they can't hear. But is that really the best way when dealing with someone with dementia?
No. Okay, next question. No, yelling at people is not the best answer, is not the best thing. So a lot of times when we think about issues around care, you're on the right track. So one of the questions that was in the list that Lisa gave me kind of fits in with this, is about kind of managing continence and managing bathroom kinds of things and reducing urinary tract infections and that kind of thing. So you were absolutely right that yelling at people does it. So what changes with dementia is not hearing. Hearing changes with aging, but hearing doesn't change with dementia. And I can put up another slide and show that. What changes with dementia is understanding. So this is your temporal lobe of the person without dementia. This is the temporal lobe of the person with dementia. So you've got that little ridge right there. So what happens is changes in receptive language and changes in formal and automatic language. So receptive language and expressive language. So what that means for us is that the person living with dementia may not understand what we are trying to communicate with them. So there are some things we can do. So everybody put up 5 fingers. Malia did this morning, I think, or yesterday, 5 fingers. Now put them together. And you see how nicely those fit, right? Now take 5 fingers on one hand and 3 fingers on the other hand. Now put them together, and what do you notice? They don't fit. So what I've got to do with 3 fingers is use 3 fingers to make them fit. So what that means is if my person has impaired processing, they can't understand. Instead of going, oh, Shauna, it's time for you to go to the bathroom because you need to get down there because it really gets to be really hard when we have to pick you up. You ready to go? And Shauna's going to go, help. And then when I go to put my hands on Shauna to help her, Shauna's going to go, help. So what we do instead is change our pace. So I might say, Shauna, hey. So Shauna, if you'll unmute for a minute and work with me a bit.
Okay.
Hey.
Hi.
It's Melanie.
Nice to meet you, Melanie.
Hey, Shauna, your hair is so beautiful.
Thank you.
Hey, you know what? Let's go look at it in the bathroom mirror.
Okay.
So now Shauna and I walk off to the bathroom. When we get to the bathroom, we look in the mirror at Shauna's beautiful hair. And as soon as Shauna sees that toilet, what is she going to need to do?
Mm-hmm.
She's going to need to empty your bladder. She sees that toilet, she needs to empty that bladder. So what I'm doing is I'm connecting with Shauna instead of just being, agenda driven and, this is what I want to do. Check, check, check. I make that connection. And then we go together and I'm using visual cues instead of just using, the talking cues. So when we get in the bathroom, if Shauna needs hands-on help, and hey, Lisa, do we have some hand under hand videos on the Mondays with Melanie, or do we need to do that at some point?
I think we have some examples in some of them, but we might need to do one just on hand under hand. In many of on YouTube and the Mondays with Melanie videos that we've done with Melanie before today, there are examples of Melanie working with someone in that hand under hand position. So you can watch those. Looks like Sue maybe has seen some of those, but yeah, you can check out our Mondays with Melanie playlist on YouTube for some of that. And Melanie, I'll write that down. We need to do more of that in the future.
I think maybe the one I did with Loy, which may or may not be available, but might be available at some point, some pieces of that. So it's this way of I've lost my glove. Oh, here's my glove. It's this way of, that's my wrong glove, but it's this way of connecting my hand with the hand of the person living with dementia, and then helping them button their buttons or unzip things with their hand with my hand. So it kind of does that. So it feels like they're doing it to themselves instead of me doing something to them. So that's one of those things about helping. So with Shauna's question about managing hearing, so what did I do differently with Shauna the second time than I did the first time? Did anybody notice and want to unmute and notice what I did with Shauna? What was different the second time than the first time? Was it, hey, Shauna, it's Melanie, I'm here to have da, 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 da. What was different the second time?
Well, you engaged with her in a positive manner and made a connection and kind of, distracted her from what your goal was, which was to get to the bathroom, and helped her want to go there herself.
Okay, so I made that connection. I didn't say we're going to get to the bathroom. You haven't peed in hours and you're going to pee on yourself if you don't pee on yourself. Because as soon as I start talking about peeing on yourself, what do? You go
It's
ahead.
punitive, not punitive.
Don't like me. And as soon as, I mean, how many of y'all have been sitting on this call almost an hour now, and I'm talking about peeing, and y'all are now thinking about what? It's been a while since I've been too. So talking about it makes me need to do it right now, and I haven't stood up. So there we go. So for many, many reasons, that doesn't work. So that's one. Now, Malia, you were going to unmute, you unmuted a little bit as well. What did you notice about the second conversation with Shauna versus the first one? Was it the same as Sherry or something different?
Yeah, pretty much the same as Sherry, just, again, using more of the visual cues, referencing the hair, and so that they're able to process a narrowed down language versus the blah, blah, blah. And they're also picking up all the visual cues as well. But then, yeah, the distraction of getting them into the restroom, which gets you to your goal and accomplishes that. So, but obviously in a much more compatible, relationship building manner. So.
Yeah, exactly. And so all of those things, what did you notice, Shauna? You wanted to add something?
It seemed like you also slowed it down and you kind of went down on a lot of the wording. So it just was easier to understand than all these words that you're saying just sound like, gibberish.
Yeah. So it's that matching, and that matching means matching her pace and matching her number of words. So if she's got dementia and she's needing help to the toilet, the chances are she's not going to have whole long complex sentences. She's going to have more, thank you, more automatic kinds of slower processing. So that's going to work and hopefully work better. So I think the only thing I haven't talked about that was mentioned was some stuff about urinary tract infections, which kind of gets into that idea that a lot of times older people with dementia, or people living with dementia as well, show those kinds of symptoms in a different way. So if one of us were to have a urinary tract infection, we might notice frequency and burning, and we might notice some odor and some cloudiness. I mean, that's what we're going to notice. If somebody's got dementia, what we might notice about them might be they're irritable and they're uncomfortable and they're restless, and they can't do things they used to be able to do. And so I'm looking for more whole body responses to specific issues. So a lot of it's called delirium or acute confusion. We could do a whole talk, and I think I have many times done whole talks on delirium. And it's that idea that somebody might have pneumonia, or they might have the flu, or they might have a urinary tract infection, or they might have their bowels might be backed up, they might be impacted, and what we might see might be anger and irritability and frustration, and I don't want to, that kind of, and so it can be deceptive what it looks like. So the things that we can do to kind of reduce that are just good, healthy kinds of things. You know, water is wonderful, but water is not the only way to manage your fluid intake. You know, watermelon, grapes, you know, pineapple, fruits like that also have a lot of water in them. Popsicles, you know, if people want, you know, so we want to get fluids in people. Eating soups, you know, that have a lot of liquid. That's a wonderful way to increase somebody's fluid intake. So it doesn't have to just be, you know, measured little cups of water. There are lots of ways. So getting a lot of water actually kind of reduces incontinence and reduces urinary tract infections. Because what happens is when people start to get dehydrated, urine gets more irritating, it gets more concentrated. That concentrated urine makes people need to go to the bathroom more often. They feel like their bladder is irritated, so that drinking more fluid actually helps people not go to the bathroom as much. So, you know, that can be bidets. I think bidet, I have some friends I was just working with using a bidet now, and it's been extremely successful, kind of helping people keep clean when motor skills of wiping aren't quite as good. So bidets can be really helpful if that person, especially if you start them earlier and the person gets used to them a little bit, it's not quite as uncomfortable and quite as scary. So I think bidets are a great thing to give a try. So that's important. The other thing that works for bladders or reducing urine, drinking lots of fluid, keeping bowels regular, because when there's a lot of stool in the rectum, or not in the rectum, but in the lower intestine, in the colon, the lower colon, and the rectum, it actually puts more difficulty in the bladder being able to empty. So that can actually be a problem. So I do that. The other thing that's really important is really emptying well. And for a lot of issues with emptying well has to do with positioning. So sitting on for a lot of older people, particularly now that toilets are higher than they used to be, they're on the toilet, their feet aren't comfortable. So people almost need something to put, and that's why I hate that we don't have phone books anymore, because phone books used to be the very, very best thing to put under people's feet, to just because you want to be in a good position for emptying your bladder, emptying your bowel. Your knees need to be at a right angle, or your knees need to be just slightly above your hip. So this is my leg. This is my knee. So I want my knees at the level of my hip or slightly above the level of my hip to really help me empty well. I also will do double voiding with a lot of people, which is someone, you know, you go to the bathroom before you get ready for bed. And so you empty your bladder, and then you brush your teeth and you wash your face, and then empty your bladder again. And that will often help make sure that bladder is really empty before hopefully a nice long night of rest.
Melanie, we appreciate your time and your insight. We went all over the place tonight and everything was so helpful. So thank you. And I really want to thank all of you for joining us tonight and sharing, because that's what makes a great conversation. So we appreciate all of you. Thanks so much for being here. And I believe next month we're talking about travel, among other things, Melanie. So we'll get to be hopefully traveling by then. So thank you all so much for the information, and do feel free to reach out with questions. We appreciate you.